So let's first start where we took off. And let's start with this. Hold on 1 second.
Doctor, are you going to share your screen?
Yeah, 1 second, Victoria. Sorry. All right. You guys able to see it?
Yes.
Yeah, doctor.
Okay. Hold on 1 second. Let me do it. All right. So who wants to take the last one? Let's start with that. Who is able, or what about this? How about you all try to do it in the next 2-3 minutes? Tell me what's going on. What's the compensation? And somebody can, you can just type it down if you want. For some reason. And if you have any question about any of the other topics that you wanted to cover with Dr. Majid, the CKD, we can talk about it, or I can give you case scenarios. Yes, you can do the last two. Meanwhile, let me try to share the slides with you because I know you guys wanted the slides. All right. So we have Dr. Hania. Can you unmute and tell us how you came up with your answer? Dr. Farhan, right? Okay. So your last one, anybody came up with the same answer? The last ABG, metabolic acidosis respiratory compensation. Or does anybody came with a different answer? Okay. I'll do the last one since you already answered it. So why would the CO2 increase? Okay. So let's take it step by step. So the last EVG, is it acidotic or alkalotic? (7.08) acidosis or acidosis. Okay. PCO2, does it go with it, the same direction, or does it go against it? So it goes against it, right? So that was if you remember from the slide. If the pH, so, yeah, exactly, so it's respiratory acidosis. So if the pH and the PCO2 go against each other, so we know that the primary disease is respiratory, regardless was it acidosis or alkalosis, right? So if the pH is going down, that's acidosis, and the PCO2 is going against it. So we know this is respiratory acidosis, right? So going back here, so we know that the primary is respiratory acidosis. What about the compensation now? Is it compensated? What would you expect from metabolic standpoint? And respiratory acidosis, what would the bicarb be? Well, let's not go to the concomitant part yet. Let's just stick with the primary one. So is it the metabolic part? Should it be alkalosis or acidosis? So increase high, right? Compensation means that you need to counteract the primary problem, right? So if the primary problem is acidosis, yes, exactly, alkalosis. So if the primary problem is acidosis, the other part we're trying to be alkalosis. The bicarb, is it high or is it low? Low, yes. So that goes against it. So without even calculating, you already know that this is non-compensated. And this is actually two diseases, respiratory acidosis and metabolic acidosis. Why not both? I'm not sure I understand what you mean by that question. Both what? He has two diseases? That's exactly what's going on. The patient has two diseases. Yes, acidosis. He has respiratory acidosis and metabolic acidosis. So he failed to compensate. That's why his pH is very low. So he has two diseases. Respiratory acidosis is the primary, right? Because they go against each other. And non-compensated metabolic acidosis. So when you say that, you know it's not compensated. So you know that the metabolic part or the renal part is not kicking in. And it's acidosis, which will make the pH worse. Now, for the sake of, let's just put it for calculation part, right? What do we expect the bicarb to be to say it's compensated? Now, if you remember when we talked last time, there's acute and chronic part, right? Higher than normal range. You mean the bicarb should be higher than normal and still have acidosis? Yeah, it can. But to say that, you need to know what is the expected compensation, meaning the normal is 24. Let's calculate what's the compensation here, right? If you remember what we said was, for every 10 increase in bicarb and PCO2, an acute metabolic should increase by 1, and chronic, for acidosis, and chronic should increase by 3. So 62 minus 40, that's a delta of 22, right? Multiplied by 0.1, which is every 10, should be 2.2. Plus 24, it's 26. So if this acute respiratory acidosis, the bicarb should be 26.2. If it's chronic, 23, 6 should be 30. So if this is acute respiratory acidosis, the bicarb should be 26 to say it's compensated. If this is chronic respiratory acidosis, the bicarb should be 30, right? So the bicarb is not even close to that, not even 30 nor 26. So when he has metabolic acidosis, no, for the sake of example, let's say the patient has a bicarb of 20, let's say bicarb of 28. Okay, if the bicarb is 28, that for chronic we multiply by 0.4, that's for alkalosis. So 1, 2, 3, 4. For acidosis, is 0.3, 0.4 for alkalosis. Let me show. 0.4, it's usually here, I could be at 0.4, but it's usually 0.3. So just keep it as 0.3 to remember it. I'd rather to keep it at 0.3, not 0.4. If you want to do 0.4, it'll be 31 to 32, because that's okay. But for the sake of calculation, it's let's say no, 28, bicarb is 28. So if the bicarb is 28 and you know that this is chronic respiratory problem, then what I would say, if it's this situation, let me change it for you. If it's 28, then I would say this is respiratory acidosis with non-compensated metabolic alkalosis. So I know that the bicarb is trying to reach the alkalotic bar, but has failed to compensate, meaning it hasn't reached the threshold. Okay, but if it's let's say 26, and this is acute, then you would say this is a compensated metabolic alkalosis. Now, it is impossible for the bicarb to go above 30 and overcompensate. So it's either compensate metabolic alkalosis or non-compensate. For some reason, I feel like everybody's confused. Do you want me to say that again? Okay. All right. So the main problem is respiratory acidosis, correct? Why can't we say this is metabolic acidosis, failure of respiratory compensation? No, you always have to decide what is the primary disease. Okay. The primary disease is what here we decided at the beginning, which is respiratory. So the main drive for the respiratory part is, I'm sorry, for this acidosis is the respiratory part, right? Clinically, the patient might have metabolic acidosis at the baseline, but the main drive for this pH is the PCO2, right? This is how we decided at the beginning when we had this lecture that if they go against each other or they go with each other, how we decide was it metabolic or respiratory, correct? Back up here. pH is 7.08, so it's low. So it's either here or here. The PCO2 is high, right? So it's respiratory acidosis. So you already decided the acidosis part based on the pH value. And then you already decided that the primary one is PCO2 because the PCO2 goes against the pH, right? So that you already established the primary disorder, right? Now you move on to the compensation. Okay, so you want to do the math, do the math. You want to do 0.4, I would suggest against it, because make it 0.3. And we'll see where the patient is, right? So we just did it just now. So 62 minus 40, that's your delta bicarb. You multiply that by the every 10 change of bicarb is 0.3 in chronic and 0.1 and acute. So in 0.1, so 22 times 0.1 for acute, that's 2.2 change of delta bicarb. You add that to the baseline bicarb, it's 26, which the patient doesn't have. Let's do the chronic. So 22 times 0.3, or if you want to do 0.4 or so just 0.3, 6.6. You add that to the baseline bicarb, which is 24, it's 30. So the patient doesn't even have 26. Delta bicarb or PCO2, both, you need both deltas, right? 62 is the bicarb, as the PCO2, I'm sorry. Minus 40, that's the baseline bicarb, PCO2, right? That's the delta of 20 or 22. And we know already for every 10 change in PCO2, regardless of the direction, there will be a change of bicarb. For every increase in PCO2, there should be an increase in the bicarb. For every drop in PCO2, there should be a drop in the bicarb, right? So this is a 22 extra PCO2. So how many tens in 22? 2 tens. right? So if it's acute, exactly 2.2. If it's chronic, 2 10s, every 10 is 3, so you get 6. So PCO2 of patient minus PCO2 range, a baseline range, it's 40 equals delta PCO2, not delta bicarb. That number that you get, doctor, or doctora, I should say, which is this one, 2.2 for the 6.6. This is the number that you will have to add to the bicarb baseline, and then you'll know where the bicarb should be at. Look at here. The delta bicarb with every 10 change and the delta PCO2. You add that to the 24, and you will have your delta. You add it to the patient bicarb. No, I didn't even touch the patient's bicarb. What I did, I added to the baseline. Yes, it does. How does it help me with the patient management? Let's say this, for example, this patient, okay? Yeah, I have respiratory acidosis. Regardless of the etiology, whether it's a severe obstructive disease from asthma or COPD, or severe exacerbation of interstitial lung disease, bronchiectasis, whatever. Then you have this bicarb of 18. Now the question is, where is this bicarb 18? It shouldn't, so you have a problem. So if I have metabolic acidosis, my question comes in, is it anaerobia or non-anaerobia? Do the math. 18 plus 102 is what? It's 120. 120, 145 minus 120 is 25. That's high. So the patient has also anaerobia metabolic acidosis. And if the patient has anaerobia metabolic acidosis, right? What are the causes of anaerobia metabolic acidosis? Do you guys remember? What? Renal, possibly. Any one of those. Gold mark. So here comes the question. Which one of these can cause metabolic acidosis, maybe cause respiratory alkalosis as well, or respiratory acidosis? Then I worry about ingestion. If the patient takes something that suppressed the respiratory drive, can we say that uremia causes hypoventilation? That's a good question, and the answer is no. Possibly. Aspirin, yeah. Possibly. See, now you're starting to think how it helps you clinically. Ingestion is a big thing in these cases. Or it could be just severe lactic acid because the patient, let's say, has severe ischemia for whatever reason. Or he might have two diseases at the same time, as you guys mentioned, renal failure. Now, where did that renal failure come from or came from, that's a whole different topic. But it does help you clinically. For this hypoventilation, the patient might need either bronchodilators, steroids, or even intubation, mechanical ventilation. For this metabolic part, the question is now, wait, hold on, did he ingest something? Should we talk about dialysis now? Should we look somewhere else? Should we look at the microscopy, look for any crystals, right? Or is it something else he's hyperperfusing that caused this anaerobia, that bicarb being consumed? So this is how we think clinically for these situations. How about we do the fourth one? Who wants to take it? Yes, sir. Okay. Metabolic acidosis of compensated respiratory. Okay, so if you want to type it down now, you understand the concept behind it. If you want to write it down professionally, the way I would say it is, yes, this is metabolic acidosis with compensated, if it's compensated, I have calculated, with compensated respiratory acidosis or alkalosis? Alkalosis, absolutely. So basics is basics, exactly. So I would say this is metabolic acidosis with compensated respiratory alkalosis. So is it compensated or not? Let's do the Winter's formula. So we said the bicarb is 10 times 1.5 plus 8 plus minus 2. So 23. So plus minus 2. So it should be anywhere between 21 to 24 is the PCO2. What's the PCO2? 24. So it is compensated, right? Okay, so now you have the compensation and you have the primary disease. Now, for metabolic acidosis, is it ion gap or non-ion gap? Is it ion gap or non-ion gap? So 10 of bicarb plus 110, that's 120, right? So 130 minus 110 is 10. So we assume the albumin is normal. So it's 10. Is that high or low? None. Non-ion gap. So why does the patient have non-ion gap metabolic acidosis? You guys remember the mnemonic for the non-ion gap? Used part. Yeah, exactly. Used part. The big thing that we usually encounter in the clinical situation is diarrhea. That's the first thing that pops out of our mouth when we ask a patient with non-ion gap, do you have a diarrhea? Most of the time it is correct, but sometimes not. Now remember, we talked about renal tubular acidosis. It's different than renal failure. No patient should have an elevated serum creatinine or low GFR and have RTA, at least in your level. They will never ever give you a question with abnormal renal function and ask you about renal tubular acidosis. It's either one of them, right? Okay. So do you need more question about ABG or that's it? We should move on to the hyponatremia. Ask about it. Can we do the 2-1? Which one? The second one? Can we do the second one? Okay, sure. Does anyone take any one of these? All right, hold on. Let me just. I have one ready for you. Let me just copy it and paste it. I will give it to the residents. Hold on. Can't seem to find it. Let me just, you know what? I'll give you one that I encountered today. How about that? Let's share this. I'll give you one that I encountered today. Who wants to take this one? course, all the question assuming that the albumin is normal. So again, respiratory alkalosis, uncompensated with metabolic acidosis. Can you tell us how? What's the formula that you used? Okay, so the primary is respiratory alkalosis, absolutely. It's high pH with low PCO2, correct. What about the compensation part? Good. If chronic or acute, the Y carb is low. Is it compensated or not? Should it be low or should it be high? So the pH is not normal yet. It should be low. It should be low. So if I understand from your writing, so you would expect that if it's compensated that the pH will be normalized. That's a pitfall that we all fall into. Not necessarily. Exactly, not necessarily. Okay. We have a lot of patients, and you'll see, because the pH, again, as we said, it's an algorithm, it's not a number, right? So it's all about the acid load. And if your body is still able to function with abnormal pH, doesn't mean it has to be normalized. Sometimes it takes days or weeks, months to go back to 7.40 with abnormal either ventilation or renal function. Or I should say not renal function, I should say how the kidneys are dealing with acid-base aminogenesis. So if I said that, let me ask you again, is this compensated or not compensated? Don't look at the pH. All right. So let's take it to it. So this is a respiratory alkalosis. NN-GAP, we'll come to it. We'll come to the NN-GAP. So respiratory alkalosis. For every 10 decrease in the PCO2, if it's acute, the change should be by 2. If it's chronic, by 4 or 4.5, right? So this is 40 minus 32 is 8, so there's an 8 change, times 0.2 for acute respiratory alkalosis, 1.6, right? So 24 minus 1.6. 22.4 if the bicarb should be 22.4 if the patient is having acute respiratory alkalosis. Now, if it's chronic, so we said 40 minus 32, that's 8. Multiply by 0.45, 2.6, right? Plus minus 2. So 24 minus 3.6, we said, right? Close. There's always the range of plus 2, right? Plus minus 2. So it's actually compensated. This is compensated. Exactly. So this is compensated metabolic acidosis. Now, is it NN-GAP or non-NN-GAP since it's a metabolic acidosis? Would you still calculate NN-GAP if it's compensated? $17, so it is high. Wait, okay. 35. And maybe you forgot to add the bicarb, right? Because what's the formula for the NN-GAP? It's the sodium minus bicarb plus a chloride, right? So chloride is 102, bicarb is 19, that's 121, so 135 minus 121. Was it 135? So 138, I'm sorry. 138 minus 121, 17. So the NN-GAP is 17. So high NN-GAP. This patient had actually lactic acidosis. That's why he had NN-GAP. And what happened is the patient became so tachypnic in the ER, and that's why he went into respiratory alkalosis, although it was chronic, but he started building up lactic acid because of the severe muscle workup for his accessory muscles, and that's why his NN-GAP increased. What's the primary disease here? From respiratory or from the metabolic? You don't calculate anion gap with respiratory alkalosis. It's not about respiratory. Anion gap is metabolic. So if you have metabolic acidosis, you do calculate anion gap, whether metabolic is primary or is it a compensation. What's the primary disease here? So for the anion gap, it was lactic acid. The patient's lactic acid was actually 3, which is 3.5, which is elevated. And the main reason why his respiratory alkalosis actually was just exacerbation of his COPD, COPD. He'd been having it for days, and he was not compliant with medications. So, although the ABG doesn't look horrible, so that's what. So metabolic led to respiratory? No. Why would you think that? The primary problem is the respiratory, right? So the primary problem is respiratory alkalosis. Patient's tachypneic, and it still didn't build up, right? And the kidney is trying to compensate by becoming acidotic or cause the loss of bicarb, right? Because if the PCO2 drops, pH will increase, right? And if the pH increases, how do we drop it again? By becoming acidotic from the metabolic part, correct? So pH is high, it was high, PCO2 is low, respiratory alkalosis. How do we compensate with that? With metabolic acidosis. So actually, the kidney is trying to compensate for the respiratory part, not the other way around. I don't want you to focus on the etiologies. This is just for you guys to know how to approach an ABG. Okay. All right. How about we move to hyponatremia? Okay. So this is a classic question for all of you. 20-year-old college student went partying, okay? And we don't know what they took. They presented to the ER for seizures. Okay. You check the electrolytes. What would you expect the electrolytes to be? The family or the friends noted that he was having excessive sweating, vomiting, right? And after a couple of hours, he started seizing. Hyponatremia. How would you treat that? Low sodium. Well, at least respect the sodium. Just say hyponatremia. You don't have to say low sodium. It is low sodium, that's true. So is it acute or chronic? That's better. Or I should say, is it symptomatic or asymptomatic? You think the seizures due to the hyponatremia? I would say so. And it's acute, right? Because it's symptomatic. That's the most important thing, right? So if he's symptomatic, hyponatremia, how would we treat that? Saline. Normal saline? 0.5 dextrose, yes, D5. In acute or severe symptoms, it's only 3%, hypertonic saline, not the saline. In hyponatremia, you don't give saline, or D5 is out of the question. You never give D5 in hyponatremia to treat hyponatremia. It will make it worse, okay? D5 will make hyponatremia worse because it's pure water, and we said this is a ratio problem. We do not want to add water to what is already being considered too high as a ratio, okay? And for the normal saline or the 0.9, you only consider if they're severely, but he is vomiting. Now, that's a good point. Let me show you this. Now, here's what we worry about. If he's vomiting, I'm assuming you're worried about volume, right? So because they might die either from volume, hypovolemia, or from severe drop in the tonicity, osmolality, right? That's why they're hyponatremic, and the brain is being started to have fluid shifting. If the volume is a problem, you have to volume resuscitate, usually hypotensive. Venous vomiting by itself is not an indication for volume replacement, by the way, as long as they're not hypotensive. And on top of that, 3% hypertonic saline will cause fluid retention, right? Eventually, it will cause fluid retention. So you're actually giving them volume as well. But the concentration of the sodium in it is too high, right? So that's the difference. The concentration of 0.9 is too low, while the concentration of 3% is too high, but they both have volume in it. D5 have 0 sodium. So you're actually going to make it much, much, much worse, right? And is the patient symptomatic from hypovolemia? Now, of course, you can tell me he's severely hypovolemic. Now it's affecting the CNS. Yes, absolutely, that can happen. But clinically, in this case, maybe I should have mentioned that hemodynamically they're stable, or at least they're hypertensive. They're not hypotensive. And if you know that, then the answer is definitely 3%. Usually we see these cases, as we said, like in amphetamines, tox, we don't know, like ingestion of some sort, and any athletic or any like marathon. A lot of patients who are in a marathon, they fall, they're hyponatremic, we give them 3% immediately from the get-go, as long as their volume status is normal. So this is how you treat hyponatremia symptomatically, right? 3%. 3%. Now, if you want to consider one of those water restrictions, they have to be chronic or asymptomatic. Diuretics is, of course, they're hypervolemic and they're chronic as well. Salt tablets usually never works, but it's out there for you to keep it in the back of your mind. Tolvaptan is also another medication that we use for chronic asymptomatic patient as an inpatient, because we only have it in an IV form. We don't have it as a pill, unfortunately, yet. Let me ask you, what is the most common cause of hyponatremia, though? What's the most common cause of hyponatremia? Hydration. You like overhydration, or you mean underhydration, like hypovolemia? Dehydration, hypovolemia. Okay. Yeah. Overhydration. So by overhydration, you mean like they're drinking too much water, correct? Good. So it's polyuria, polydipsia, right? No, actually that's not the most common cause. Most common cause of hyponatremia. Diuretics. Diuretics cause hyponatremia by hypovolemia. Drug-induced. Close. How would drug cause hyponatremia other than diuretics? Close. How does drug cause hyponatremia? Which one of these etiologies can drug cause? Can a drug cause beer butamania or tea and toast diet? No. Can a drug cause heart failure? Not acutely. Cirrhotic? Again, not acutely. Nephrotic syndrome? Nope. Can a drug cause renal failure? Yeah, but Not acute lobar hyponatremic. SIDH. SIDH is the most common cause of hyponatremia in asymptomatic chronic patients. Keep that in the back of your mind. So that's why, because we know it's chronic, whenever we have hyponatremia asymptomatic, we immediately tell the other physician on the other line, like, just restrict their fluid intake. Give them 1 liter. We always start with 1 liter. Give them 1 liter. And then we can work them out. That's from the hyponatremia part. Now, how about the hypernatremia? The classic questions for hypernatremia is we're going to find a lot of patients who are either bedbound, nursing home, elderly, unable to find a source of water intake. Dehydration, absolutely. That's the most common cause. And it's very simple. The treatment is, as we discussed before, it's just give them water. D5 water. D5 water. Let me ask you about the CKD before we move on to the AKI and CKD. What did you guys in touch base with CKD with Dr. Majid? What was the answer for the most common cause of hypertension? I already said that. SIDH. Yes, they do. Diuretic can cause hyponatremia, and hydrochlorothiazide is notorious to cause hyponatremia, but they're not the most common cause. Yeah, I will come and talk to him. Don't worry about it. Just leave the patient for me. Once I finish, I will come and talk to him. Yeah, keep it on. Don't worry about it. I'll finish the lecture, then I'll go talk to the patient. Thank you. Diuretics can cause hyponatremia, but they're not the most common cause. SIDH is still the most common cause. SIDH can be either due from infection, drug-induced, malignancy, right? Anything that can cause an excessive, inappropriate ADH secretion. And what is notorious is SSRIs, antipsychotic medications. That's a classic question. A patient who is psychotic or depressed, taking a form of SSRIs or anti-tricyclic medication, that will have this hyponatremia, and the cause is most likely to be SIDH. Dr. Majid, when he touched base with you guys about CKD, what did you guys cover? Because I wasn't able to get his lectures. Sorry. For God's sake, somebody can unmute and tell me. I feel like I'm talking to myself here. Mostly was AKI. So you guys didn't talk about CKD at all? Really? Well, that's bad. Because I'm pretty sure you're going to be asked about it. And management. Okay. That's a problem. Yeah, let me see what I can do. Hold on 1 second, guys. Here is his lecture. Yeah. No, this was AKI. I thought he said CKD. Well, he told me something. You send it to my email? Here, where? Oh, yeah, okay. Found it. Let's open it up. some reason it's not opening up. Okay, anyways. That was unexpected. Really was not expected that. Hold on once. Let me open it. You guys able to see the slides, right?
Yeah.
Okay, good. So I'll skip all the intro. Let me skip all of this. I want to move on to the most important part of CKD. I'm not going to talk about GFRs. Okay. What do you need to know about CKD? That it comes in stages. All right. There's a lot of big data that's been looked at throughout history, regardless how we measure the GFR, whether we use what we call CKD AP formula, or we use the MDRD, or even cysteine C. CKD comes in 5 different stages. Something we call G1. So that means that the estimated GFR is above 90 ml per minute per surface area. Stage 2, stage 3A and 3B, 4 and 5. Now you might ask, why is that important? Having stages can help us what do you call it? Like understand what's the complications that is expected and how soon should we expect the patient to be on dialysis, and more importantly, when to prepare for dialysis for these patients. All right. So let's go. What is CKD? So CKD is basically there's a kidney damage. It's not just AKI for more than 3 months. So either structural or functional abnormality. So if you have an AKI, you have a normal serum creatinine that was 50 or 60 micromole per liter. And then there's for whatever reason had an AKI and now it's 130. After 3 months, the serum creatinine is still 130. So we'll call it chronic kidney disease with a baseline serum creatinine of 130. Where does that put the patient on the stage? Most likely we'll put them at G3, 1. Okay. So anything less than GFR 60. Why do we go with 60? Why is it more important to have CKD stage or like the stage 3 A or 3B? We don't care really much about 2 or 1 because 2 and 1 did not show any change or difference in mortality, most like 3A or above. And this is where we need to intervene as nephrologists. Any patients with this, if you do a nuclear scan and found their, let's say GFR is 75, 80, we don't do anything to them. You don't need a nephrologist, but anything lower than 60, this is where our job kicks in, right? This is a classic picture that you will always find for the CKDs and how do we stage it. And you look at the prognosis. So if you can already assume that red is bad, right? So it's based on the GFR and the level of proteinuria. So if anything about kidney you need to know, as we already mentioned from the glomerular disease, proteinuria is bad. Serum creatinine, a low GFR is also bad. So if you put them together, you're trying to find out where the patient is at from this picture. If you say GFR is 45, so okay, so he's here, or she's here, and they have, let's say, proteinuria more than 300 milligram per gram, sorry. So that puts them on high risk. These reds, it means one thing. It means that they have high risk of cardiac or like coronary vessel disease. So they might die from heart disease, acute coronary syndrome, atherosclerosis, like strokes, you name it. So this is why we try to avoid these reds. So if the patient already lies down here, we're trying to bring them up anywhere else. So this is when we start treating those patients, right? So how do we treat those patients? So this is about the proteinuria, the stages of the proteinuria. A1, A2, you're not going to be asked about it. All you need to know that it's different stages. And the higher the proteinuria, the more worrisome you should be. That means that there is a proteinuria. That means there is a glomerular disease. The normal is 30 or less milligram per millimole. Milligram per, 30 milligram per gram, right? So 3 milligram per millimole. So anything less than that, it should be. Anything above that, then we have a glomerular problem. So all these are comorbidities that comes with CKD. Diabetes, hypertension, coronary vascular disease, age, any infection, obesity. Two most important things you need to know about diabetes and hypertension, right? These two are the most common cause of the community-acquired chronic kidney disease that we see in the hospital here. What you will see in the next couple of years, if you do your rotation of nephrology at King Faisal, is actually different etiologies because our patient population is different. But out there in the community, diabetes is still the #1 cause of chronic kidney disease. Obesity as well. Does anybody know how can obesity cause chronic kidney disease? I think we already touched base on it. Not sure you guys in the chat. Usually FSGS. Exactly, yes, FSGS, secondary FSGS. Or obesity, absolutely. That's how we cause CKD. Now, these are the different types, as you can see. Diabetic nephropathy comes #1. Hypertension, nephrosclerosis, it's an entity that is going to change with time. We used to say it whenever we don't know the cause of the CKD, because usually hypertension is the only thing that is obvious as a culprit, but now we know better to say that most likely the hypertension is secondary to the CKD, not the other way around. But as you can see, GN is very low. It's only 5%. All right. So this is mostly for resident. Let me just jump into, all right. Nope. I will share the slides with you guys. I don't want you to worry about it. I thought Majid gave you the slide. So how do you slow the progression of CKD? So what can we do to slow the progression of CKD? So if we know the patient is CKD stage 3A, 3B, they're going to end up being 4, they're going to end up being on 5, they're going to end up on dialysis. Can you reverse it? No. Once the damage is there and you label the patient's chronic kidney disease, you cannot reverse it. What's the ultimate treatment? Treatment, not management. Treatment for CKD, it's transplant. But we do not transplant those patients when they hit stage 3B or 3A or even 4. We wait until they become 5. Unfortunately, this is the situation here in King Faisal. But ideally, whenever they are at 4, we should start transplanting them. But because of how short we are with organs, we have to wait until they become dialysis dependent, and then we go for transplant, or if they have a living related donor. So you cannot treat it. You can only slow it down to push the dialysis further. Any day not on dialysis is a good day. So how do you slow it down? All right. There's a lot of trials that done in the past that looked into it, but the most important thing that you need to know, we already talked about it, is the RAS inhibitors. Hold on one second. So you have RAS inhibitors, ACE and ARBs, right? Transplant. So what does ACE and ARBs do to the kidney? They drop the glomerular hypertension, right? You already know how this ACE and ARBs work, right? They're gonna cause what? Afferent arteriole, what? Dilation and efferent constriction, right? So by doing that, it asks the kidney not to work as much by filtering, but it will actually cause filtering by increase the hyperfiltration itself, because it increases the volume inside. So it will be by diffusion. So it dropped the glomerular hypertension, this is exactly what we want, because if you ask the kidney to work very hard, it will become scarred. And we don't want the glomerular to be scarred at all, right? And of course, the whole target, what you need to know about RAS inhibitor is this the drop in or decrease in the albuminuria. So it's actually protective, because you're not asking the kidney to filter much protein. which it shouldn't do to begin with, right? All right. What MRAs, mineralocorticoid receptor agonists? It it dropped the proteinuria and also dropped the tissue fibrosis. An example is spironolactone, usually in higher doses. So now you have two medications. You have ACE and ARBs, and you have spironolactone, right? All right, and then this is just to compare about blood pressure. So you give the medications, but you know that these medications also will cause hypertension. So does blood pressure play a role? Yes, I already told you that one of the complications of CKD is hypertension. So does the keto diet help? It's a good question. The answer is no. I'll tell you why. But let's stick with the hypertension for now. You need to have a target goal for blood pressure. The more uncontrolled the blood pressure is, the more likely the CKD will progress faster. So if you have two patients, one patient who has CKD, both of them actually has CKD 3B, and one's blood pressure on ACE is 120/80, and the other one is 130/90. Which one is going to progress faster? The uncontrolled blood pressure, right? There's a lot of guidelines to tell you what's the target blood pressure in CKD patients. But now we have a unified number, finally, after all these years. And we can say any CKD patient should have blood pressure, whether it's diabetic or not, as long as they have proteinuria. Blood pressure is 120/80. It has to be normalized, whatever it takes to normalize it. Okay? So that's regarding the hypertension. Another complication of CKD is acidosis, right? Remember the anti-ganglion failure? There you go. So why is that important? Now, it will increase the oxidation of the branch amino acid. So you're going to have more free amino acid that cause acidosis. The severe acidosis will break down the proteins and also drop the albumin synthesis. It's pretty bad for the vitamin D. And that's why one of the reasons why a lot of CKD patients will be having hypo or low vitamin D, right? Not just because of the decrease in the synthesis, but also because of the impaired problem to begin with. And this will also increase the bone metabolism and of course bone lysis as well. Upregulated of ammonia, as we mentioned as well, from the acid base, which is going to be bad because you're trying to get rid of the acid, right? So this will cause increased ammonogenesis. Accelerated CKD progression. The more acidotic the patient is, the faster the CKD progression is. And that's why the treatment is to give sodium bicarb. Because at the beginning of the CKD, usually patients will have non-anti-metabolic acidosis. So that's why we can reverse it with sodium bicarb. And the target should be normalized to 20 to 24. Right. All right. Now, these are the treatments for diabetic kidney disease. The only thing that I want to touch base on, I think I already talked to you guys about, is the SGLT2 inhibitors, right? Sodium glucose cotransporter. Now they are actually almost part of the guidelines. If it's up to me, as I said before, I will give every household SGLT2 inhibitor to take it, whether they have diabetic or not, whether they're CKD or not. This is how much we believe in this medicine. Okay. All you need to do, it does reduce albuminuria, it does induce weight loss, and more importantly, now this is a question mark, but now we know it's actually renal protective. So it's good for the heart, it's good for the kidneys. That's why we need to give them as well. Metformin is part of the treatment for diabetic kidney disease, but it does not have renal protection to it. It protects the kidney by decreasing trying to manage diabetes. SGLT2s tackle both. So that's why we like the SGLT2 as nephrologists. Statins. Now, statins actually, it was big for the cardiology people. It's huge. And everybody was on statin for all patients who have high risk of cardiovascular diseases. But we know now that not all CKD patients benefit from it, but we still give it. The evidence is weak, but what we know is actually there's some improvement and the proteinuria, not the GFR, just the proteinuria, and this is what we're trying to treat. So if you have a CKD patient, I would put them on statin, whether they have hyperlipidemia or not. The evidence is weak, but we do it. Now, if they end up on dialysis, we remove the statin because there's no point of it anymore. So this is, as you can see, this is the clinical guidelines or where we go with. This is our almost Bible, and it's suggested, nothing more, but they suggest to put those patients on. Now, this slide, I think, may be one of the most important slides of this PowerPoint presentation. Is that, as you can see, all these GFRs, and when will the complications will have. So it summarizes to you the complication that is expected from every CKD stage, and when do you expect it. So if you can see here, if the GFR is almost 80, like 2, we might start seeing hypertension. If the CKD becomes at 55, so CKD is 3A, we will start seeing high PTH, which is secondary hyperthyroidism. So we already have 2 problems: hypertension, hyperparathyroidism. And when they hit 3B, we start seeing, most likely they were going to start being anemic. And less than 3B, 4, they'll become hyperphosphatemic. Acidosis and hyperkalemia usually present very late when they are at CKD 3B or 4. And uremia is way late, less than 15 of GFR. So this slide actually tells you what is the expected complications, when to expect them. Of course, they might overlap. This is not a guideline. So it doesn't mean that you will not, that all patients with GFR of 55 or 50 will have high PTH. No, most likely they will, but it doesn't mean that all of them will, right? So this is also what you need to know. So this is very important one. This is for the cardiovascular disease. I think this is above it. But one other point that I would like to touch base on is the chronic kidney disease and mineral disease. The mineral bone disorder in CKD is a well-known complication, and it's actually involves many aspects of how you tackle it. The PTH will increase, right? Why would the PTH increase? Does anybody know? A lot of people trying to, no, the PTH stands for what? Parathyroid hormone, right? Hypocalcemia, no, close enough, but not hypocalcemia. So, hyperphosphatemia, yes. The way I remember, or I've been taught about PTH, is that PTH stands for phosphorus throwing hormone. So every time the PTH is high, it's trying to get rid of phosphorus. That's from nephrology standpoint, okay? Now, I know that PTH is more sensitive to calcium, but that's for endocrine to talk to you about. Let me focus on the phosphorus, right? So the kidney actually is accumulating phosphorus. It's actually the body is accumulating phosphorus because the kidney cannot excrete phosphorus. So that's why PTH goes up. Of course, the hypocalcemia also goes down. Why does the hypocalcemia goes down? Because the vitamin D synthesis is also low. So you have low absorption of calcium, you have low synthesis of vitamin D, and you're trying, so you have now 2 problems. You have hypocalcemia and hyperphosphatemia, and that's why you have high PTH. How do we tackle this? First thing we try to do is replace the vitamin D. Why? If you replace vitamin D, you will increase the calcium absorption, right? Trying to drop the PTH. So active form of vitamin D is the best way to go initially. We're not going to touch base on calcinomimetics and stuff like that, okay? Anemia is well-known complication of any form of chronic diseases, right? You already know anemia of chronic disease. I keep hearing all the time, anemia of chronic disease, anemia of chronic disease. It's mostly going to be normochromic, normocytic. But the only thing that I can tell you is that diabetic tend to have earlier anemia than the rest of type of CKD. The worst type of anemia comes with chronic tubular interstitial nephritis. Okay. You don't need to know this. Oh, this is the target for anemia. So the goal is 10 to 11 hemoglobin. We do not want to normalize it. We do not normalize hemoglobin because we know now for a fact any hemoglobin above 11.5 is associated with strokes, especially with dialysis patients. So what we say, no, let's keep it closest to normal, right? So what erythropoietin is what we try to treat those patients, right? Now, let me try to give you, this is about the diet. Okay. Somebody asked me about the keto diet. For the key, so what we know is initially a lot of people thought because if there's high protein in the system, there will be hyperfiltration of the kidney from the inside, intraglumerular hyperfiltration. So that's why they said drop the protein in your diet, try to lower your hyperfiltration. But what has been noticed that actually those who dropped their protein diet had drop in their serum creatinine, true. But because, and if you have low serum creatinine, automatically you'll have better GFR. But that was not a true improvement in the structure of the kidney. That was actually artificial in the sense that they start losing muscle mass. And if there's no muscle, they won't be a creatinine. Now, not all patients, of course, will have loss of muscle mass, but this is why one of the ideas why the low protein diet caused this lower in serum creatinine and improvement in the GFR. So, but they noticed that there's no difference on the initiation of dialysis. They're still uremic at some point with lower, with a little bit improvement of GFR. So that's why we put a guideline now. Excessive protein is bad because of hyperfiltration. Low protein is pretty bad as well. Is exactly the same. So both extremes are wrong. So we need to find a middle ground. The keto diet is not going to help any form of diet, right? No, there's no specific diet that will improve the filtration. We might see some new studies coming along in the next year or two, but until then, no nephrologist should ever suggest to a patient low protein diet. What we usually suggest is like, just do the right thing. Just don't eat much like red meat because of your cardiovascular disease to begin with, your hyperlipidemia, right? But I don't want you to shy away from it. We still need the protein as well. So there is like a recommendation of like how much protein they need to take. Any questions so far? No. So if I have to tell you something about CKD, expect what? It's low GFR. There's a complication that you need to know. And one of them is, we already said, the low GFR will come, we said hyperphosphatemia, hypocalcemia. What would you expect the potassium to be? Okay. What about the sodium? Why low? It is low, actually. No, it's not high. It will be low. Why low? In CKD, it's not reabsorbed. It's actually hypervolemic in renal failure. It's not because they're losing sodium, because it's not going to be reabsorbed. They're hypervolemic because they start having a problem with volume. So classically, at end stage, of course, later on with the CKD, classically, you will have patients who are hyponatremic, hyperkalemic, hypocalcemic, hyperphosphatemic. That's a classic CKD. Dilutional effect. Well, hypervolemia, we said it's a ratio, right? It's a ratio problem. So yeah, they have more water than salt. I think I went over time, but it's my mistake and I apologize for coming late, but I really thank you all for staying this late. I know a lot of people just left, but that's okay. Any, other than the slides, do you guys have any questions? So, yeah. If anybody has any question, but when is your exam? Okay. If you have any questions, throw me an email. Can I explain what? Sodium levels. Okay, be more specific, please. What do you want me to explain? In renal failure, in advanced renal failure, right? Let me put this one. Here we go. This is an advanced renal failure, right? Advanced renal failure, right? They will have higher water intake, right? Or like hypervolemia. And they will also start losing salt, correct? Based on the news you guys mentioned. They'll start failing to reabsorb because the kidney is not working. But the kidney will have what? Decrease in urine output because it's not working the same. So it's a ratio problem more than anything. The effect of the volume reabsorption or failure to filter, I should say, failure to put out urine is the main reason why they're having hyponatremia. Now, they will have, of course, problem reabsorbing because the kidney is not working the same where it is. So if the kidney is not working the same, cannot reabsorb, right? That's what you guys mentioned. And the kidney is also having problem secreting because it's already advanced. So that's why they become hyponatremic. They're hypervolemic. That's the main reason. And then also because decreased urine output. And of course, they're not reabsorbing as much sodium. And that's why when you check the urine sodium in advanced CKD, you'll find it high. And you say, like, why is it high? Are they having renal salt wasting? Because the answer is no, they're just having advanced CKD. You're welcome. Focus on CKD, focus on ABGs, focus on the sodium, and you guys will do fine. Okay. Okay. Yes, I will. You're welcome. Okay. Do you have any good resource for hyponatremia? Yeah, any textbook. I would say in your level, do you guys study from, I've heard first aid, I heard like whatever stuff, USMLE stuff. Yeah, first aid. Well, I don't, last I checked first aid, that was 15, 20 years ago. It was horrible. I'm not sure how it is right now. But if you want, let one of you guys email me that chapter of first aid about the sodium. I can let you know if it's good or bad. And it should be enough or not. Boards and beyond. I don't even know what that is. Okay, that's fair enough. Enjoy your long weekend. Thank you guys for giving me this opportunity again. And again, I'm sorry I'm late.
Thank you, doctor, for taking the time.
Thank you all. Have a good weekend. Thank you.